It's 8:01, and I welcome everyone to Grand Rounds. And again, thank you for spending an hour increasing your knowledge about medicine, even on this cold day. So my little fun weather fact is, I don't know if any of you were up on Sunday night, but it was the February full moon, and that full moon was aptly named the snow moon. And if you were up on that night, the snow had cleared, that 6 inches of snow was there, and it was so bright outside that night. It was beautiful. So today, I'm very honored to introduce Dr. Farhan Raza, who is a CHS assistant professor in the Division of Cardiovascular Medicine, who's going to be doing grand rounds today on pulmonary hypertension, the physiological phenotyping, and role of exercise. So a little bit about Dr. Raza. Dr. Raza earned his medical degree from King Edward Medical University in Pakistan. He did his internal medicine residency at Temple University in Philadelphia. He then went on and did his fellowship in cardiovascular disease at the Temple Heart and Vascular Institute, and he was honored during his fellowship to be a chief cardiology fellow. He then went on and did a research fellowship at Temple, and finally, for the last of his fellowships, he did a fellowship in advanced heart failure, transplant, and pulmonary hypertension at Cornell University. He finished that in 2018, and we were very lucky to have him join us on faculty after his fellowship. So he's been here since 2018, and that's a very short time. He's done an incredible amount of things in his first year and a half with us. He has been very involved in education. He's involved with the Cardiovascular Fellowship core curriculum. And when I was reviewing his CV, he's really done an incredible amount of CME in the area of pulmonary hypertension around the state as well. He's involved in 2 clinical trials where he's a site PI and a sub-investigator looking at treatment in pulmonary hypertension. When I was looking through his CV as well, he's had 11 refereed articles from his fellowship days until now. And as far as awards, really speaking to the work and the love I think he has for education, in 2014 at Temple, he received the Best Fellow Educator Award for excellence in teaching cardiovascular disease to medicine and surgical house staff. And he also achieved the Chief Appreciation Award for excellence in role in teaching, leadership, and clinical practice as a senior resident at Temple University. So with that, Dr. Raza, please come up and give grand rounds.
Thank you. Thank you for inviting me. Oh, it's a little too loud, I think. It's probably a little better. So pulmonary hypertension is a fascinating field for me. I'm a little biased, but it really challenges us on a day-to-day basis given the natural overlap of the kind of patients that might be coming through a pulmonologist or a cardiologist office. There's a significant overlap with not just internal medicine, but you may not think, but we get to interact a lot with even specialties like oncology, nephrology, and GI, and that's a very broad group of patients. So on a really typical day, anybody can walk through the door, and it presents a really interesting challenge that we have to think through. It really keeps us on our toes. So just to give you a flavor of how a typical kind of patient flows through the clinic, I'll start with a clinical scenario. So this is a patient I saw a while ago, a 57-year-old female complaining of shortness of breath with exercise, and the kind of patient that is seen in a broad, kind of diverse group of clinics, and had a past medical history of hypertension, obesity, sleep apnea, remote history of pulmonary embolism. So by the time she saw me, she already had an echo and was labeled with a diagnosis of PH. Naturally, that's how she ended up in our clinic. But let's take that away for a second. And how many of you have dealt with a patient complaining of shortness of breath with exercise? probably almost everybody in different situations. So let's delve into the challenges this typical scenario will present to us in our day-to-day practice. First of all, just the symptom of shortness of breath. You can name it in many different ways. Breathlessness, it's a very subjective feeling, which if a patient is telling you they are breathless, they're short of breath, or they are experiencing dyspnea, the story ends there, and now your work begins. The second more frustrating part is the nature of the symptom with exercise, which presents a very interesting challenge for clinicians because a lot of diagnostic testing we have available, echo, cath, different functional testing or anatomical testing, is really focused on resting studies. So that becomes a little bit of extra challenge in a small cohort of patients. Now, the last part, personally for me, even after the diagnosis of PH based on an echo, which is the screening study that picks up pulmonary hypertension, the challenge just begins there. Like, what should we do next from there? Because not everybody is the same. Now, for the rest of the talk, just for simplicity, I'm just going to use dyspnea instead of shortness of breath. But this really sums up the bulk of the talk, like what we're going to focus on. This one simple patient scenario, teasing through these simple steps. And that sets the goals for the talk. First of all, we'll kind of try to understand dyspnea itself and how does that lead to the diagnosis of pulmonary hypertension. The second more meaningful aspect is going to be phenotyping of pulmonary hypertension, thinking a little more physiologically. And the last part is, what is the role of exercise testing in some of these patients, not everybody, and how do we pick up where exercise is needed and is helpful? So we'll go through these in a stepwise way. We'll start off with the just epidemiology of dyspnea and PH itself. So I'm going to present a little interesting scenarios. So depending on your day-to-day practice, let's say if you're a primary care doctor, and if you're seeing a bunch of new patients, just try to take a guess in your mind what percentage of those patients will be coming into your office with dyspnea. That number is going to be 25%. That's a huge proportion of patients complaining. So if some of you may have clinic today, and if you're seeing 4 new patients, first of all, if you're seeing 4 new patients, you may be having a bad day. But 1 out of those 4 are going to have dyspnea. So you'll have to deal with this situation, hopefully, at some point. And then what about the emergency room? People who are just presenting to the ER with anything. Almost 12%, that's a huge proportion of those patients will be experiencing dyspnea at rest or with exercise. And almost half of these people get admitted, roughly. So if you are used to dealing with these patients on the inpatient side, that's a huge proportion of patients who you'll be dealing with. And lastly, in a cardiologist or a pulmonologist office, and I'm not talking about a PH clinic, almost half of those patients, if not more, will be experiencing shortness of breath. So it's a very common symptoms. A bulk of patients that we see in a day-to-day practice are experiencing this symptom. Now, what do we like to do when you see a patient? Naturally, the first step that you would do is talk to the patient and try to get a sense of, what is your suspicion, what could be the underlying reason for them to experience the symptom. So knowingly or unknowingly, you are really trying to divide dyspnea patients into like one of the 2 big buckets. Is there a more system-wide or systemic cause for them to experience shortness of breath? It could be anything. They could be incredibly overweight, obesity may be a problem, or some other medical problem, like they may be severely anemic that is causing exertional shortness of breath. But the more interesting part, and again, I'm biased when I say this, is a cardiopulmonary cause of dyspnea. And even within that path, when it comes to thinking of next steps in any workup one might do, there are 2 particular subsections. One I would call a cardiologist path. So, you will think about getting an ECG. If you want to do some blood work, you could check a troponin, among other things. And there's a pulmonologist path, thinking about the lungs. So you will naturally think about getting a cath scan of the chest or pulmonary function test, thinking about diseases like asthma, COPD, or interstitial lung disease. But at some point, either a cardiologist or a pulmonologist would want to know if there is something more going on with the heart. And that's where you will think about getting an echo. So how many patients, here's a question, who have shortness of breath do end up getting an echo? Actually, nobody knows the answer to that. And that's really difficult to answer. But let's say based on your clinical suspicion, going through the severity of symptoms the patient are expressing to you, going through their past medical history, trying to identify the risk factor profile, you do decide to get an echo. So coming back to this particular patient, so I think it was very appropriate to get an echo in somebody like her because, again, she has quite significant risk factors that any one of these things could be contributing to her experiencing shortness of breath. And in this clinical scenario, the patient was quite short of breath, so very appropriate to start off with an echo. So now here's the next question. Let's say you do decide to get an echo in this patient. A lot of people who are getting a first-time echo, actually not just for dyspnea, but for any other reason, how many of them will have pulmonary hypertension? And again, just take a guess in your mind. That number is 18%. So almost 1 in 5 people, and this does not include everybody with dyspnea. This could be an echo for any reason. And this statistic actually comes from an interesting paper out of Medical Center in Israel. They studied close to 20,000 people out of an echo lab, people getting first-time echo and just picking up PH as a diagnosis. That's a pretty high number. And if you were just to focus on people experiencing shortness of breath, I presume this number is probably going to be even higher. Now, in some estimates, people have estimated that up to 3% of the whole population likely has PH. And again, these things are quite difficult to quantify, so that I think there is some speculation in there. But that number may not be very off. And the 1-year mortality is still incredibly high. For any disease to have a 1-year mortality of 26% kind of tells you a lot. Now, in the following slides, I'll delve a little bit into the diversity of PH and how PH can be a really mixed bag of different things. But lumping it all together, still 26% is a pretty high number. But the one part that actually, the first time I found out this one particular aspect of PH as a disease that really surprised me, from symptom onset to the diagnosis, what is the timeline? Like, how long does it take? Do you have shortness of breath and a month later, you seek care, you get the PH diagnosis? No. That number is 13 and a half months. There is a significant delay. And when you think about it, it kind of makes sense. It's not surprising in any way. The symptom is so nonspecific. People don't even know, especially if it's happening in a very gradual way, what really is, at what point do they seek care, or at what point they just say, oh, maybe I'm just getting old. So let's delve a little bit into the clinical manifestations. So as I hinted at earlier, the most common symptom for PH is going to be dyspnea, shortness of breath with exercise. People do sometimes complain of fatigue as well, which is a slightly different symptom. It has more to do with kind of lack of energy. And it's a subjective difference. Sometimes patients can't even differentiate that symptom. The third one, which is seen in some very advanced stages of PH, is exertional syncope, which happens in situations where you're just unable to kind of augment a good enough cardiac output even when you're doing very minimal exertion. So you're basically just not sending enough blood to the brain as you walk, and the moment you start walking, you just pass out. The fourth one is chest pain. So surprisingly, a lot of people who have PH can have a lot of indirect strain on the heart, direct or indirect. That can cause subendocardial ischemia, and that can trigger a chest pain symptom as well, which is very different than what we see in kind of coronary artery disease-related chest pain. And lastly, people can start having fluid buildup. That can lead to weight gain as well. But those are some of the key things to look for, kind of teasing out the dyspnea symptom itself and trying to get a sense of how severe someone's symptoms might be. Now, the next part is screening for PH. So as I hinted a little bit, even in the first slide, the screening for PH is always based on an echo. So the echo is an excellent study. It provides such a wealth of information about different chambers of the heart, their size, their function, what the heart valves are doing. And then there are some very neat Doppler parameters on echo as well. But the one simplified thing relevant to the world of pulmonary hypertension, you get an estimate of pulmonary pressure. And if it's above a particular number, for most echo labs, it tends to be 35 or 40, you get the diagnosis of pulmonary hypertension. So if you will get a report if you order an echo on somebody with all of this kind of different list of information, as I was hinting at. But pH tends to be like really at the bottom of the list. So, and it's a pretty standard echo report, not unique to UW. It's pretty standard for every center. And being a pH cardiologist myself, this actually hurts my feelings a little bit because pH is so low. And one of my life goals is to get it up in the top 3 at least. I know it's never going to be number 1. I'm realistic, but got to try. So the next step is really trying to understand the diversity of pH. So there is such a broad group of diseases that lead to pulmonary hypertension, and a lot of physicians who, or clinicians and scientists who try to cover the whole group have defined a way over the last few decades to clump them together into 5 different groups, which we call World Health Organization or WHO groups. And that they do an excellent job at making sure everything that can possibly under the sun cause pH comes under one of those 5 groups. But it kind of makes the topic a little more difficult. But just to mention those 5 in particular, the first one, we generally call them an arterial group, or traditionally they were called primary pulmonary hypertension or pulmonary arterial hypertension. The second one is a venous group, which is kind of reflecting some disease on the left side of the heart. Could be anything, heart failure with preserved ejection fraction, reduced ejection fraction, valvular heart disease, mitral valve, aortic valve. Could be anything. But that causes some backward congestion into the lung circulation, and that's a venous group because it's causing congestion through the pulmonary veins back into the pulmonary circulation. The third one, easy to kind of call it an obstructive group, but it's really implying something going on with the lung parenchyma itself, lung tissue. Again, it could be COPD, interstitial lung disease. Those are a couple of common ones. Sleep disorder breathing actually falls in the same group as well. Obstructive sleep apnea. And then the fourth one, which is a unique group of thromboembolic pulmonary hypertension. So a little more simplified way of thinking about it, if somebody had a PE and an unresolved clot, that can linger around in the lung blood vessels and cause some remodeling of the lung blood vessels. And that's a thromboembolic pulmonary hypertension. And then 5 is like a mixed bag of a broad group of different diseases. But the most meaningful to kind of remember in the 5th group is somebody who has a dialysis fistula or a graft, which is causing high flow through the pulmonary circulation. So they can cause high flow heart failure or high flow pulmonary hypertension. But a lot of things that we see in the PH clinic fall in one of these 5 groups. Now, the diagnosis of PH, having said it all, the symptoms, the screening tests, the different groups of diseases, the final diagnosis is based on invasive hemodynamics, or what we call our right heart catheterization. And it really comes down to one pressure. And you can't do a PH talk without mentioning something about the hemodynamics. So I'll explain a few aspects of most meaningful information that we get in hemodynamics from a right heart cath. But the first number to know is a mean pulmonary artery pressure. And more than 20 is defined as the diagnosis of pulmonary hypertension. It doesn't matter what is the underlying cause or what group a patient may belong to, but the mean peer pressure has to be more than 20 to get the diagnosis of pulmonary hypertension. So I'm going to delve a little bit into what a right heart cath is, what simple pressures that we obtain, and then we'll kind of loop it all in of 2 to 3 things that you really need to know about the numbers in a right heart cath. So stay with me on this one. So let's start with pressures. or the second part is going to be blood flow, and lastly, we'll delve into the idea of resistance. So the way we actually start off our right heart cath, we basically just put a IV catheter or a sheath in one of the veins. So I almost always pick the internal jugular on the right side of the neck, get a venous line similar to actually a triple lumen catheter put in the ICU or in different setting as well. Same blood vessel, we put a catheter in, and then have a little pressure wire, which you can kind of appreciate going through the jugular vein, all the way sitting in the right atrium in this particular picture. And you can hopefully see there's a tiny kind of almost looks like a swelling, but there's a balloon at the tip of that catheter. So that tip itself, the balloon lets the catheter float normally within the blood. Otherwise, it'll be just hitting the side wall, and it gives a very neat tracing. But the tip of that particular wire has a pressure transducer. So on the outside on the monitor, we can actually see the pressure waveform wherever the wire tip is. So at the lower part, you can see a rather like flat waveform, look like a road bump almost. So that is telling us, as we're doing this procedure, what the right atrial pressure is, because you're in the right atrium at the moment. As you advance, the balloon tip kind of moves into the right ventricle. So you see the pressure waveform, and it goes, you start getting like a systolic and a diastolic pressure as you would in left ventricle as well. And as you advance further into the pulmonary artery, you see the diastolic pressure rises. So pulmonary circulation is kind of very parallel to our systemic circulation. So we're so used to thinking about blood pressure of like 120/70. So the same concept kind of translates into the pulmonary circulation. You will have a systolic and a diastolic pressure. So the normal is somewhere in the range of 25/10. And then you get a mean pressure, which kind of correlates in most cases with the diacrotic notch. And there are a couple of methods which we use in a day-to-day practice to estimate the mean pressure. But the mean pressure just roughly is a little lower than half of what your systolic and diastolic is, for simplistic reasons. I'll put it that way. So somewhere where the arrow is pointing out, you will get a mean pulmonary artery pressure. And that's the number I was mentioning, that the mean pulmonary artery pressure is the cutoff that we use to diagnose somebody with pulmonary hypertension or tell them that they do not have pulmonary hypertension, and the cutoff is 20. Lastly, as we keep advancing the catheter, eventually the balloon will get stuck in a very small branch of a pulmonary artery. And for simplistic reasons, we just call it gets wedged in a small branch of pulmonary artery, or we call it the wedge pressure. So why do we worry about the wedge pressure? Like, why do we even care? It actually has incredible meaning in the diagnosis of pulmonary hypertension. So I'll pull up this different kind of diagram, which is meant to make this just one point about the wedge tracing itself. So again, just to point out what we're looking at here, so this kind of black, tiny, twiggly wire is the same catheter that we were looking at traveling through different chambers on the right side of the heart. And as it advances into the pulmonary artery, eventually it gets stuck. It gets stuck in a very tiny branch, and we get the wedge pressure, we get the wedge tracing. So why do we even care? It's meaningful because it's actually giving us an estimation of a left atrial pressure. So it's telling us the story on the left side of the heart, which we really want to know, which is very meaningful. What's happening on the left side of the heart while we're also checking the pulmonary pressure? So how does that kind of give us an idea of the left atrial pressure? So theoretically, as you're in a wedge position, the left atrial pressure will get transduced back through the pulmonary veins, through the pulmonary capillaries, and through the small little branches of pulmonary arterioles. So you're kind of transducing that pressure, and it has a decent correlation to give us that idea. So the short answer is the wedge pressure is giving you ideally left atrial pressure and telling you the story on the left side of the heart. Now, to sum it all up, those are the only two things that you need to know, like what those pressures are, and they're very meaningful in the world of pulmonary hypertension. What is your mean pulmonary artery pressure, and what is your wedge pressure? And whenever I use that word, I'm kind of implying the left atrial pressure or the left-sided heart pressure. The second piece of info, and then the pressure gradient that we sometimes define across the lung circulation is just the difference of these two pressures. And I'll come back to this in the next few slides. Why does that matter? The second part is blood flow. So there are some methods for us to kind of calculate the blood flow. We use the word cardiac output very frequently, and that tells us how much blood flow in liters per minute is just generated by the heart in a resting condition, and that we can estimate through a right heart cath as well. And that normal range is somewhere in the range of 5 to 6 liters. For smaller people, we have to consider 4.5 as a normal range as well. And lastly, the idea of resistance. So the resistance, so the right heart cath is telling us the pressure and the flow. Resistance is just estimated based on those two parameters. And I'm referring number 1 and number 2. It's not meant as a joke for any gastroenterologist in the room. So what is the idea of resistance? I'll spend a few moments here of how do we, in a very simple way, how do we estimate resistance in lung circulation, and why does it matter? So in any circuit, it could be electric or vascular circuit, for it to have a meaningful blood flow or current for an electric circuit traveling through it, you need a high pressure right where the circuit begins. And you kind of need a slightly lower pressure, so you have that pressure gradient to maintain that blood flow or electric current flow. And that pressure difference is basically driving that flow. And it's a very simple idea. If you have a high pressure at one moment and a low pressure, and it's similar to how water flows in a river. In some of those situations, there's an effect of gravity, but there's a high pressure at one point and a lower pressure on the other point, and that maintains the flow of the water to go from one direction to the other. Otherwise, the flow would be static or start going back in the other direction. So that pressure difference is meaningful in understanding why there's blood flow going in one way. Now, using the Ohm's law, we can actually divide that delta or change in pressure or pressure gradient, you may call anything, but it truly is that pressure from the high to low and divided by the flow, and it gives you a number which we call the resistance. So another kind of simplistic way of trying to make sense of this, if you, in any circuit, if you have a very high pressure gradient, the high pressure point is very high, the low pressure point is very low, and that's maintaining a significant amount of flow. Since the flow is a denominator, that's why I'm using the lower arrow. So in that situation, actually I take it back, I meant to say if the flow is very low despite a very high pressure gradient, that will give you a very high resistance in that circuit. But let's look at the other scenario. If the pressures are very low, but it's still maintaining a very high flow through that circuit, that will give you a very low resistance. And that defines how the characteristic of that particular vascular system will be. But I'll try to simplify a little bit here. So the last couple of slides, I think I might have been a little introduction of a little physics there, but coming back to a clinical scenario, how does all of this translate into pulmonary circulation, which is the topic of interest relevant to our talk here? So flow is our cardiac output that we just calculated from the right heart cath. The high pressure where the pulmonary circulation is starting off is your mean pulmonary artery pressure. That's where you just started. And the low pressure, or the end point of the pulmonary circulation, is right where the pulmonary veins drain into the left atrium. So we were trying to estimate that left atrial pressure, or the wedge pressure, and this is where the story becomes interesting, because now we can assess that pressure gradient across the pulmonary circulation. And the formula is incredibly simple. You take that pressure difference and divide it by the cardiac output, and it gives you a very simple parameter of resistance in the pulmonary circulation, or what we call pulmonary vascular resistance. Now, if I've lost a few people, I'll bring you back. The simple things that we get from a right heart cath that I want you guys to know of, one was mean pulmonary artery pressure. The second one was the wedge pressure, or the left atrial pressure. And then the second part was cardiac output, or the flow. And that kind of provides us the opportunity to calculate the resistance in the lung circulation. Now, what do we know so far? Let's kind of like catch up a little bit, and anybody who might have joined us a little late, well, I'll summarize of what we have gone through so far. So we kind of went through identifying dyspnea as a very non-specific symptoms, but if you suspect somebody may have some organic cardiopulmonary disease, consider getting an echo, and this is not meant to increase the business for Peter Rocco. And it really is like a clinical sense, trying to get a sense of how severe their symptoms are, what risk factor profile they have, but do consider getting an echo for screening for pulmonary hypertension. The second part is just to appreciate the kind of a non-specific like combination of clinical manifestations of PH and the diversity of PH, what possible long list of diseases can lead to pulmonary hypertension. Again, screen with an echo, and the confirmation test will be with the invasive test, right heart cath. Now, that kind of like sets aside goal number one of this talk, which is mostly like an intro to PH. Now, let's come back to this patient that I was seeing in the clinic. The question was, she has all these symptoms, she has good risk factors, and now we know that she got an echo, and now she has a diagnosis of PH. And now, based on what we just went through, we all know that the next step is going to be a right heart cath. So do we just, send her for a right heart cath blindly? That is the most interesting question to answer, and that's where the bulk of like the rest of the talk will revolve around. And to answer that question in a very meaningful way, first of all, we really need to understand the pathology of pulmonary hypertension, what's really happening in the lung circulation. But I'll even take a step back to understand the pathology really well. You gotta know like what is a normal pulmonary circulation, what is a normal physiology in lungs, lung blood vessels, and the right ventricle. So we'll start off with the physiology of what I call the exercise apparatus. And this is a very simplified picture of parts of our body which are meant to help us exercise. So it involves lungs, pulmonary circulation, heart, and then the systemic circulation, and then the blood being delivered to the muscles. And that's what we really need in our day-to-day life to work as human beings. But for the sake of this talk, I'm going to ignore that systemic circulation, just stay focused on the heart, pulmonary circulation, and the lungs. And I think Adam is not going to like that I'm ignoring the systemic circulation here, but we'll stay with this. So again, this particular like apparatus, basically everything in our chest involves lungs, pulmonary circulation, heart, and lastly, the more interesting part is the blood-gas barrier. And I'll actually translate this into a different diagram, which becomes a little more easy to understand as we're going to go through the following few slides to understand the physiology. And in this particular diagram, just to point out a few things, the right ventricle, LV, is on the other side. Obviously, they're both clumped together, but when you're thinking about physiology, they're really kind of worlds apart. Lungs and pulmonary circulation, and the blood-gas barrier is just like really between the lungs and pulmonary circulation. And the way I think about a pulmonary hypertension patient, if I truly believe they really have a cardiopulmonary cause of dyspnea and they already have a PH diagnosis, I'm trying to identify the cause of dyspnea somewhere in this circuit. So this is like really fresh in my mind every time I'm seeing a PH patient, and that's what I want you guys to think about. The problem is arising somewhere in this space: LV, RV, pulmonary circulation, lungs, and that's the whole story. But easier said than done. I do want to talk about the blood-gas barrier in particular to kind of make you understand the normal physiology a little better. So what is an efficient blood-gas barrier? And ignore, humans, ignore mammals, just talk about every living being in the animal kingdom. Like, what does a normal blood-gas barrier do? It just allows blood exchange, or gas exchange, I should say, between air and our blood circulation. So think about the alveoli and the interaction of pulmonary capillaries. For a very efficient blood-gas barrier, it has to be incredibly thin. So you can, have time for that exchange to occur. But to allow that blood-gas barrier to be very thin, the pressure which is being kind of faced on the circulatory side or the pulmonary capillaries has to be very low. If the pressure is high, that barrier is going to just rupture and cause a lot of trouble. So those are the two features of an efficient barrier that will have a very thin membrane and a very low pressure, and compare that to an inefficient barrier that will be incredibly thick, but it will be able to sustain a high pressure, which we sometimes call a hydrostatic pressure in the lung circulation. Now, I'll give you a couple of examples, kind of extreme examples, to make the same point. So on the left, you're seeing a circulatory system of the fish. On the right, taking a really jump forward in evolution, looking at the circulatory system of the mammals. Since those pictures are very distracting, I'm going to get rid of them for a second. So let's talk about the fish. They have a single ventricle, single atrial system. It's the same high pressure that the fish has to deliver to all circulation. Doesn't differentiate between systemic or pulmonary circulation. Now, the same high pressure going into the rest of the body of the fish, it's hitting the gills as well. That's where the gas exchange happens in fish. So that's why the gills have to be incredibly thick just to sustain that pressure. Now, compare that. Obviously, it went through a long list of steps through the evolutionary process, but compare that to a circulatory system of mammals, including us. With time, there has been separation into systemic circulation and the pulmonary circulation. The systemic circulation has the same high pressure to deliver oxygen everywhere in our body, and that's why the pressure is so high in the aorta, and that's why the pressure, our regular blood pressure is like 120/80. But compare that to the pulmonary circulation. Because of that nice separation and ability to have that thin blood gas barrier, we were able to achieve a very low pressure pulmonary circulation, which is not just low pressure, but it's also very compliant. There is a very rich network in pulmonary circulation, so that even at rest, we have low pressure. But when we exercise, with exercise, there's more blood flow, the cardiac output goes up, the pulmonary circulation just expands nicely, or at least it should in the normal situation, to kind of make room for that high flow without increasing the pressures. And that kind of requires a separation of systemic and pulmonary circulation. And I believe that's why the fish is so grumpy and the orangutan is so happy, because it can exercise more. And that really evolutionary process, in this figure, I'm just pointing out how the blood gas barrier actually really thinned out with evolution. So it really got from like 1.6 to 1.8 range in fish all the way down to close to 0.4 in mammals. And in birds, it's even smaller. So how does that translate into our talk here? So given that really low pressure, highly compliant pulmonary circulation, the pressure seen by the right ventricle is incredibly low. So the RV tends to be very thin walls, small size, and in simple words, the RV in a normal situation doesn't have to work that hard. That's why it doesn't have to be muscular. But the left ventricle is the bigger pump. It has to pump a lot of blood forward at rest and with exercise. So in this figure, I do want to introduce like this one very simplistic kind of view of the heart on echo. So the right upper side is the left ventricle, which you can kind of appreciate. It's occupying the bulk of the space in the view because it's the big pump. The one below LA is the left atrium. On the other side, RV is the right ventricle, the lower chamber is the right atrium. And the reason I'm introducing this one particular view, because in the following slides, I'm going to show you what goes wrong and what abnormal looks like. But this is what a normal heart looks like. Hopefully, if somebody does an echo on one of us right now, this is what our heart should look like. And again, the last thing I want to point out is the septum between the left atrium and the right atrium that I've pointed out with an arrow. And the reason I'm pointing this out, because the interatrial septum is so thin, every time something goes wrong, either on the left or right side of the heart, and there's a slight difference in pressure in both sides, the septum can tell you the story very quickly. It starts bowing one way or the other. And I actually try to stay away from this idea, but I can't help at least introducing the term. Because of this low pressure, high compliance pulmonary circulation, and a thin-walled right ventricle, we use the word on the clinical side and more so on the research side in pulmonary hypertension world of coupling, or a more simple way of thinking about it is the pulmonary circulation and RV are kind of married to each other. It works well for both of them, and they're coupled. And then when things go wrong in some pathology, when they are just discordant and the RV starts to fail, we use the word RV uncoupling. And there are many ways for us in the research side, including pressure volume loops, to assess that in a more neat way. But for the sake of this talk, I'll leave that particular idea out there, but I just wanted to introduce the term. So now let's delve into the pathology. So we'll start with the pathology of dyspnea before we get into the pH. Now, there are some challenges that are presented in the pulmonary circulation that, really, that's where the trouble starts. And it really is that simple. We got to identify what that challenge is. And that indirectly puts stress on the heart, because obviously pulmonary circulation is directly attached to the right ventricle. Anything that goes wrong there, RV is the first one to face the trouble. And to kind of compensate for that challenge, the RV starts working a little hard, starts generating high pressure, and that's truly what pulmonary hypertension is. That high pressure gets picked up on the echo, and then subsequently on the right heart cath. And in the process, very frequently, depending on how sick or how symptomatic the patient is, in some cases, they are so advanced that, as clinicians and research scientists, we think about the idea of RVPA uncoupling in this scenario as well. But for the sake of this talk, we'll leave that term alone. But the simple idea is coming back to kind of defining what are those challenges, and can we define them in a simple way to understand pulmonary hypertension in a more simple, straightforward way. So I'll go back to this particular figure and introduce two different kind of big groups of pulmonary hypertension when it comes to the challenges that arise in the pulmonary circulation. The first one is kind of a volume challenge that arises on the left side of the heart, and anything, again, on the left side of the heart, HFrEF, HFpEF, valvular heart disease, that starts to rise pressure on the left side of the heart in the left ventricle, left atrium, and that causes backward congestion into the lung circulation. And in this particular scenario, there's nothing really wrong intrinsically with the lung circulation, but there's so much backward congestion that it increases the volume and increases the pressures. The second particular phenotype is pressure overload, where there's some underlying pathology in the pulmonary circulation, and that starts to increase the pressure while the left side of the heart is fine. So the pressure challenge kind of presents as a high resistance phenotype, and the volume challenge presents as a low resistance phenotype. It's another way of thinking about, in the high resistance phenotype of PH, there is some intrinsic pathology with the pulmonary arteries, which is causing high resistance. While in the volume challenge, the pulmonary arteries are kind of rather normal, at least early in the stage. And the problem is kind of backward congestion, hence the resistance is low. Now, eventually, we do want to really drill down to one of those 5 groups of pH that we were chatting about earlier, the 5 groups I mentioned a while ago: arterial, venous, obstructive, thromboembolic, everything else. So, but for the sake of simplicity, thankfully, we can kind of move these groups around and lump them into one of those 2 physiological phenotypes of volume overload or low resistance, or pressure overload or high resistance. The 3 groups: arterial, which we used to call primary pulmonary hypertension, or now pulmonary arterial hypertension; lung-related problems, or thromboembolic disease, which is kind of unresolved pulmonary embolism; and then the rest of the group of left heart disease of any phenotype, or AV fistula-related PH. So these 2 groups kind of behave differently. So the first one behaves as the high resistance pulmonary hypertension. The second one behaves as a volume overload or low resistance PH. And that truly is the whole idea of physiological phenotyping. Your life will become much easier, seeing a patient of PH. You can really tell straight away what physiological phenotype you might be dealing with. And that's, I'm oversimplifying it, but that truly is how simple things are. So we'll talk about the physiological phenotyping a little bit more here. A little different diagram I'll introduce here to kind of make the similar point. So in this, I'm just splaying open like pulmonary circulation on the left, and then the left ventricle and kind of pulmonary venules on the right side. And this is where, the line is drawn, right at the pulmonary capillary. So everything to the left, every disease pathology that arises on the left of it will be high pressure, high resistance, I should say, pH, and everything on the right side will be the low resistance pH. So we also, given it's coming before the pulmonary capillaries, we very frequently use the word pre-capillary pulmonary hypertension, but it's very synonymous with the same idea of high resistance pH. And that is defined by kind of looping in those right heart cath kind of concepts that I was mentioning earlier, the mean pulmonary artery pressure more than 20, and since the left side of the heart is normal, that wedge pressure, or the left atrial pressure, should be normal. So we use the cutoff of 15. And lastly, the resistance parameter I was mentioning, pulmonary vascular resistance, the cutoff we use is 3. So for pre-capillary pH or high resistance pH, mean PA is going to be more than 20, which is true for anybody with PH, but the wedge is going to be low, less than 15, and PVR will be more than 3. The opposite is true for the other phenotype of pH, which is, again, arising distal to the pulmonary capillary. So we just call it post-capillary pH. And again, the mean pH is going to be more than 20, which is common for all pH. But the wedge is more than 15, and the PVR ideally should be less than 3. So let's summarize some of these new ideas that we've kind of like introduced here. The idea of physiological phenotyping of pH, and that truly is high versus low resistance pH, or pre-capillary versus post-capillary pH. They're synonymous words. But I haven't mentioned anything, how can you tell between those two? Because in the previous slide, I was just showing you the hemodynamic numbers. So what I was, saying is those things are really truly defined still based on invasive hemodynamics. But coming back to our patient, the question I had asked, do we really need to do a right heart cath on her, or is there something that we can identify along the way? Because that's a big question to answer in our day-to-day practice. You got the echo, you have pH, but do you just right heart cath everybody, or does that idea of physiologic phenotyping really help you take a step further? So the answer to that is yes. So non-invasive testing, mostly echo, and I'll talk a little bit about some other testing, especially cardiopulmonary exercise testing, can really help you make that differentiation really early on. So you can put a patient in one of the two buckets, pre-capillary pH or high PVR pH versus low PVR post-capillary pH. And the reason it's meaningful, if you look at the left side, the group of diseases like pulmonary arterial hypertension, thromboembolic PH, or lung disease, there are a group of diseases that need special treatment from the pH point of view in the form of oral drugs or some surgical treatment to get that clot out. But on the right side, the treatment really is focused on the left heart disease or fistula-related problems. There's really nothing you could do if you give these people pH drugs, it will harm them more than it will help them. And that's why it's very important for us to make that differentiation as early as we can. So I'll introduce this one picture back again. This is, again, what a normal heart looks like. And look at this one. So the one on the left group will be the pre-capillary pH echo. Again, in a group of these patients, the left side of the heart is going to be normal. So if you look at the left ventricle on the kind of a right side of the picture, LV, it looks pretty small. It's moving okay. And then the left atrium is also pretty tiny. But the right-sided chambers are completely blown up, comparing to the normal picture I just showed previously. And the one key part that I was kind of hinting at earlier, look at the atrial septum. It's getting squished from right to left because the left side of the heart is so normal that the left atrial pressure or the wedge pressure is likely very normal or it's low, but the right-sided pressures are completely blown up. And the septum is really bowing from right to left. Given how thin it is, it's very reactive to changes in pressure on the left and right side of the heart. And compare that with this guy over here. So I kind of intentionally picked a picture for people who might be used to looking at echo images. This particular person, actually, the LV function looks fine. The size looks rather normal. I picked an example of somebody who has HFpEF, or preserved ejection fraction. But the left atrium is completely blown up. If you just look at the real estate occupied by the left atrium in that picture, it's huge compared to the normal echo. And the septum is going from left to right, which is telling you the story that LA pressure is likely significantly higher compared to the RA pressure. And that's your answer straight away. First time I get a PH referral, the first thing I do, even before talking to the patient, pull up the echo and look at this image. And that tells me the answer very quickly. Now, in the interest of time, I'm going to skip the next few slides. They were meant to kind of delve a little bit into some of the other echo features that can really help us differentiate the pre-capillary versus post-capillary pH. But I'll skip through some of these slides for some of the cardiology friends in there. This particular one was meant to show the septal flattening that happens in pre-capillary pH that is related to the increased RV free wall stress. And then the apex starts to open up in pre-capillary pH and the RVOT Doppler notching pattern. But the final message on the note of echo was basically just to make that differentiation, that this guy on the left is going to have pre-capillary pH, the one on the right is going to have post-capillary pH. And sometimes I like use this phrase quite frequently, the most important chamber in the evaluation of pH is left atrium. Because, you could be looking at variety of problems in the LV, RV, RA, and there are complex patients that sometimes we see in pH world. But if somebody has a dilated left atrium, they likely had some reason to have an elevated LA left atrial pressure or left-sided pressure over a prolonged period of time. They are going to behave like a post-capillary pH patients. This comment gets me in trouble because the survival in pH is defined by how good your RV is, despite everything else what's going on. But truly, when it comes to diagnostics and making this differentiation, always look at the size of left atrium. Now, I'll try to actually introduce this idea very briefly, the idea of cardiopulmonary exercise test, and I'll go back to this particular figure. And again, a normal, like the way we breathe without even realizing, we're consuming oxygen through our lungs, and cardiopulmonary exercise test can actually, like the face mask that we use to assess gas exchange, can actually quantify the amount of or quantity of oxygen we're consuming as we exercise. So that particular parameter is called VO2. And then all these like little nice red boxes get into our blood vessels, go to a left ventricle, get delivered to the muscles. The muscles use a couple of oxygen molecules and then produce some carbon dioxide. And that gets traveled back through the venous system to the RV, gets blown out by the lungs. And that particular CO2 quantity can be quantified again by the cardiopulmonary exercise test. So this very simple idea of our ability to consume oxygen efficiently and blow off carbon dioxide, it's a very simple idea, but that truly is the basis of utility of cardiopulmonary exercise testing and how that machine interprets these things. And that's a topic for another time, but really that particular ability is tested during a cardiopulmonary exercise test, and that can help you differentiate between pre-capillary and post-capillary pH as well. And then there are some other parameters that I'll kind of skip through a little bit in the interest of time again. But a high end-tidal CO2 pressure, which is the same parameter actually people who work in the ER or inpatient side, if you ever see a patient who's intubated, now we use very routinely the end-tidal CO2 monitor. So it's the same parameter which is checking the end-tidal CO2 for adequate ventilation or perfusion. So a high end-tidal CO2 is good in the pH world as well, and a high VCO2, meaning you're blowing off adequate amount of VCO2, is good. We use a ratio of VE-VCO2 as well, so that should be low. And that tends to be, all of these parameters tend to stay normal, at least early in the course in a post-capillary pH patient, because the lung circulation itself is rather spared. And they become very abnormal early in the course of pre-capillary pH as well. So that differentiation can be picked up in a cardiopulmonary exercise test as well. In some patients that we see in clinic, quite frequently depending on the situation, we do pursue a cardiopulmonary exercise test for this differentiation as well. And I'll skip through some of these slides, but this has been shown, some of these CPET parameters in the PH world. And we actually had a few, we published some data on exercise right heart cath. So this is what actually I do in a very selective group of patients after getting a right heart cath through the IJ access, have patients exercise in the cath lab and use the metabolic card for cardiopulmonary exercise testing at the same time. So we do it twice a month in a very selective group of patients. So this kind of sums up the second aspect of physiological phenotyping, that you can identify that phenotype based on the echo features. And for somebody who you have a suspicion they really have precapillary pH, you rather want to get the right heart cath or invasive test very urgently, because then you are going to do something about their pH with meds or some surgical treatment for thromboembolic pH. For postcapillary pH, you can forget about it. You can just focus on the left heart disease, and they can be a little on the slow track to further diagnosis. So that was the goal too. Now coming back to this particular patient, so that's what her echo showed. Her echo is kind of RV is a little blown up. The left atrium maybe is a little dilated. The septum is trying to bow from right to left, but it's not really squishing into the left atrium. So kind of leaning towards precapillary pH, but we don't know. And then the amount of pH that was picked up on the echo was very mild. That's the other thing we do pay attention to. So she actually, in particular, it was reasonable to do a right heart cath before she was referred to us. She already had a right heart cath, and these are some of the numbers I'll mention. So her mean PA pressure was 20, right at the border where the pH diagnosis is, and the wedge was pretty low, 8. Cardiac output was 4.1. She was a little tiny, but even for a small person, you may recall I said 5 to 6 liters is pretty normal for a cardiac output. We do index it to body surface area, but 4.1 was really low for her. And the pulmonary vascular resistance at rest was 2.9. So it was getting close to 3, but not hitting that 3 mark. So pretty underwhelming hemodynamics at rest, if you ask me. But she was complaining of significant shortness of breath. And these are the kind of scenarios where exercise testing can be very meaningful, when there is a little bit of a discordance of a patient telling you, I'm incredibly short of breath. And you do realize, looking at the echo, something is wrong. But then, if you just do a normal invasive hemodynamic study at rest, not impressive hemodynamics. So that's where the role of exercise is. When in doubt, add exercise physiology. So we exercised her on a 10 watt per minute protocol on a supine bike. She got up to 43 watts, had a reasonable peak VO2. So even at rest, when I started the hemodynamics on her, I also hooked up the cardiopulmonary exercise test machine. So you notice her end-tidal CO2 right from bed is pretty low. Her VEV CO2 is quite high. So even at rest, I knew, the second piece in our kind of phenotyping exercise was already showing some abnormal parameters. So that gave me a hint that when I exercise her, something bad is going to happen. Not technically, bad hemodynamics. So these were her hemodynamics. So some of the interesting kind of things to point out, I did mark them in red. So her mean PA pressure just jumped from 20 to 76. Wedge kind of stayed below 15 range, but with exercise, actually, even if you go up to 20 to 25, it's considered within relative normal range. The cardiac output went from 4.1 to 7. So in a normal situation, we should be at least able to double our cardiac output when we exercise. So people who are more athletic, they can even go as high as 2.5 to 3 times. And then the PVR really jumped all the way up to 8.8, so significantly abnormal response. And in the normal lung circulation, if one of us were to undergo this exercise cath, I would predict our PVR at rest is going to be 1.5. But when we exercise, we'll have such a good cardiac output response that our PVR will drop even more to 1 range or something like that. So just to kind of based on that, I think she had a set diagnosis of precapillary pH, and that is kind of sums up one of the indications for exercise pH. And again, that was the last few slides are mostly for that particular patient who ended up having thromboembolic pH and underwent thromboendarterectomy. And this is the last slide. It kind of sums up the 3 goals that we had set for today: understanding dyspnea, screening with pH. We're really looking at the echo to figure out the physiological phenotype of pH. and then kind of identifying which track to put the patient on. Fast track for pre-cap PH, get an urgent cath, and a slow track for left heart-related post-capillary PH. Thank you.
Thank you, Dr. I think what we're going to do in the interest of time, please come forward with any questions. Thank you very much.
Thank you.